call this meeting to order. Welcome to meeting number 58 of the House of Commons Standing Committee on Health. Today we are meeting for 2 hours to consider the Supplementary Estimate C, the main estimates and the departmental plans. In accordance with today's meeting is taking place in a hybrid format pursuant to the House Order of June 23rd, 2022. We have one member of the committee participating virtually. In accordance with our routine motion, I'm informing the committee that Mr. Généreux has completed the required connection tests in advance of the meeting. First, allow me to welcome the Honourable Jean-Yves Duclos, Minister of Health, who's joining us for the first hour. He is joined by the following officials from the Canadian Food and Inspection Agency: Sylvie Lapointe, Vice President, Policy and Programs from the Canadian Institutes of Health Research, Dr. Michael Strong, President. From the Department of Health, Stephen Lucas, Deputy Minister, Jocelyn Voisin, Assistant Deputy Minister, Strategic Policy Branch, Dr. Supriya Sharma, Chief Medical Advisor, Health Products and Food Branch. From the Public Health Agency of Canada, Heather Jeffrey, President, and Dr. Howard New, Deputy Chief Public Health Officer. Thank you all for taking the time to be with us today. We'll begin with opening remarks. Minister Duclos, welcome to the committee. You have the floor for the next 5 minutes.
Bonjour et merci, Monsieur.
Good morning, and thank you, Mr. Chairman. Thank you for giving me this opportunity to speak to you today on the 2023-24 main estimates for health. As you have noted, I'm joined by Deputy Minister Stephen Lucas, Joe Voisin, Assistant Deputy Minister for Strategic Policy at Health Canada, Dr. Supriya Sharma, Chief Medical Advisor and Senior Medical Advisor, Health Products and Food Branch at Health Canada, Heather Jeffrey, who is the new Chair of the Public Health Agency of Canada, and I would like to welcome her to her new duties. Dr. Howard New, Deputy Chief Administrator at PHAC, Dr. Michael Strong, President of the Canadian Institutes for Health Research, and Sylvie Lapointe, Vice President of Policy and Programs at the Canadian Food Inspection Agency. On February 2nd, Prime Minister Trudeau announced a plan to work together to improve health care for Canadians. That includes additional investments of $46.2 billion over 10 years. This includes $46.2 billion, in fact, for new funding to provinces and territories, and $2.5 billion in additional federal support. This is a collaborative plan where the federal government works with provinces and territories to achieve real results for healthcare workers and Canadians. In addition to these guaranteed increases in the Canada Health Transfer, $25 billion in bilateral funding will be dedicated to shared health priorities, including improvement of access to quality family medicine care where people need it, especially in rural and remote areas, supporting our health workers to retain, train and recruit more, and to recognize the skills of workers trained elsewhere, improving access to rapid surgery, improving access to equitable and quality mental health and addiction services, and working together to modernize the healthcare system so that Canadians have access to their own electronic health data, which can be shared with healthcare professionals to improve the quality and safety of the care they receive.
Canadians is a top priority of the health portfolio now and in the months and in the years to come. The main estimates I am presenting today reflect just this and identify the actions we're taking towards that goal. In total, I'm seeking $10.5 billion on behalf of the health portfolio, which includes Health Canada, the Public Health Agency of Canada, the Canadian Food Inspection Agency, the Canadian Institutes of Health Research, and the Patented Medicine Prices Review Board. I'll start with an overview of Health Canada's plans. The 2023-2024 main estimates reaffirm Health Canada's focus on providing services that are important to people in Canada, including the implementation of an interim Canada dental benefit plan. To achieve this and other objectives, I'm seeking a total of $4.1 billion. As you know, the COVID-19 pandemic exacerbated existing mental health and substance use challenges for people in Canada. My colleague, Dr. Caroline Bennett, will provide later today details on the investments that address these challenges. The main estimates of the Public Health Agency of Canada propose a total budget of $4.2 billion for 2023-24. This proposed spending will help ensure that PHAC has resources in place to continue to play a pivotal role in safeguarding and improving the health and well-being of Canadians. PHAC's main estimates include funding for the procurement and deployment of COVID-19, Mpox, and domestic influenza vaccines. CIFA, the Canadian Food Inspection Agency, also has an important mandate safeguarding food, animals, and plants, which enhances the health and well-being of Canadians, our environment, and our economy. CFIA has a proposed net increase of $4.3 million in its 2023-2024 main estimates, which will enable the agency to continue to contribute to the health and prosperity of all Canadians. As Canadians learn to live with COVID-19, the importance of investing in health and medical research becomes more important than ever. CIHR's proposed spending on health research for 2023-2024 is $1.4 billion. Monsieur le Président, en conclusion,
In conclusion, Mr. Chairman, these investments show how determined the government is to continue supporting health and healthcare for all Canadians. These commitments will be set out in greater detail in our departmental plans, recently tabled. They will also be examined today. Thank you for giving me the opportunity to make these introductory remarks, and I will now be delighted to answer all questions and comments you may have. Thank you, Mr. Chairman. Thank you, Minister. We'll begin with Dr. Ellis, 6 minutes.
Chair, and thank you to all the witnesses and to the Minister for being here today. Healthcare is always going to be a significant and important area for discussion for all Canadians, and perhaps now more than ever, given that the system is in a significant state of flux and change, of course. Mr. Minister, if I might start with active pharmaceutical ingredients. These are the building blocks of medications, of course. One of the concerns that I would appreciate if you would share with the committee today is that of remote inspections. Historically, there would be on-the-ground inspections for active pharmaceutical ingredient producing nations. Of course, due to the pandemic, remote inspections have become perhaps more the norm. That being said, we're looking at potential drug shortages given to contamination, which we've seen historically in Canada, and certainly we know that at the current time there is a significant shortages of every oral pediatric antibiotic. And if you could comment, sir, on the mitigation processes for those drug shortages which we're like to occur in the future.
Thank you for that great question, and thank you for your interest in this issue, which is obviously a great source of concern, of stress, and sometimes distress for families and their caregivers, patients certainly, and clinicians across Canada. And that's why, as you suggested, we have made some important progress over the last years when it comes to the production and the inspection of those facilities, some of them obviously involving collaboration with provinces and territories, and in some contexts with international producers and importers. But on the specific of inspections, and remote inspections in particular, I would like to turn to, if that is fine, to Dr. Sharma.
Thank you, Chair, for the question. So in terms of the remote inspections, it's true that we did rely more on those over the pandemic, but it wasn't the first time we were doing those sort of paper-based assessments of facilities. So first of all, the remote inspections were on the lower lowest risk products, such as the APIs, which have other controls on them as they go through the drug manufacturing process. And the second part of it is that we were building on a lot of work that we've done internationally with confidence building with our international partners through organizations on how best to use those types of information. We would still prioritize for an in-person inspection anything that would be of higher risk, again, not just because of the product, but because of potential issues with any of the other finished products that we go into. So really it's a risk-based approach that we take to inspections, and during the pandemic that allows us to pilot a few other IT solutions as well that helped enable those inspections.
Well, thank you very much. And through you, Chair, if I might, is it not true, though, that nitrosamines have been a significant contaminant in medications that we brought here to this country and has caused certainly rolling shortages in very common medications? Certainly in my experience as a practitioner in antihypertensives, causing significant consternation to Canadians and needing to change which medication they're on, sometimes on a monthly basis, which of course can cause confusion and potential health risks to those patients.
Again, that's a great question, and we have Dr. Sharma, who is also an expert. Now, coming from you, Dr. Ellis, I think these questions are very appreciated, and we feel not only the concern, but also the expertise behind them. So please, Dr. Sharma.
So yes, it's true. We've had recalls of products based on nitrosamines. So nitrosamines, as you know, it's an impurity that can happen from manufacturing. We were seeing more products test positive for nitrosamines over the past few years. It may be that we're also having better technology in detecting them, but we're working internationally with our partners, specifically on the European medicines agencies, to work on sharing information on how to improve the manufacturing process, and also being very clear about what limits are acceptable, because there are certain limits for the products that are acceptable in terms of nitrosamine levels and others that may potentially cause longer-term problems. Certainly anytime there's a recall, we're always weighing the risks and the benefits of that, and very cognizant of the fact that people are depending on these medications and it may not be that easy to switch. So definitely not just a Canadian issue, a global issue, and the international collaboration on getting to the bottom of the manufacturing processes that may give rise to these higher levels of impurities is ongoing.
Thank you very much. And through you, Chair, to the Minister, if I might, I think this issue is such a significant importance to Canadians that we'd appreciate regular updates on that, because I think there is somewhat of a difference related to perhaps remote inspections and the concerns and the drug shortages we already have. So we would really appreciate that. I have perhaps a minute or so left, changing gears significantly. The spotted lanternfly, a significant pest that we're concerned about coming to Canada. However, the approach to mitigating this is to perhaps look at all the lumber coming into Canada, which is about 3% of the traffic coming in, which would cause significant bottlenecks at border crossings. There are pesticides in the States, 3 of them, as a matter of fact, that could be used in Canada. We know that those used in the United States are not affecting the wine and other consumables in Canada. So why would we not license these products in Canada?
Very good question again. So these are matters related to both regulatory issues and as well as enforcement issues connected, as you signal, to the border rules that must be applied to protect the health and safety of Canadians, as well as the health and safety of whatever we produce here on Canadian soil. Again, I would suggest that I should turn for the right level of answers to you, perhaps. DM Lucas.
Thank you, Mr. Chair. Within Health Canada, the Pest Management Regulatory Agency works closely with registrants or those seeking registration of their pesticides, and has a rigorous review process in terms of ensuring the safety of those products with respect to human health and the environment. It is an open process, so should a registrant choose to bring their product to the Canadian market, we welcome their submissions and have an engagement to help support them provide those submissions and then the rigorous review of those.
Thank you, Dr. Lucas. Ms. Sidhu, please, for 6 minutes.
Thank you, Mr. Chair, and I'm sharing my time with Adam, and thank you all the officials and Minister to coming to our committee and giving us input and update. Minister, recently you were in Brampton in meeting many leadership with the local healthcare community. You heard the CEO of William Osler, one of the busiest health system in Canada. We know the wait times and backlogs are very concerning. The purpose of the immediate one-time Canada Health Transfer top-up and how it will address the urgent needs. Can you expand on that?
Thank you, and I was indeed very fortunate to be able to visit you, Sonia, just a few weeks ago and meet with lots of experts and caregivers and patients, including the representatives from the William Osler organization. Now, we know that COVID-19 has impacted lots of Canadians, but also in particular young and younger Canadians. And that's true in all sorts of ways. No? Lots of mental health issues, obviously, for adolescents and others, but also backlogs in surgeries and diagnostics, which have an impact not only on the short-term well-being and health of these younger Canadians, but also on their long-term prospects in life. And that's why the $2 billion that you are signaling is so important. It's an immediate $2 billion that is going to be sent to provinces and territories very soon to look after the crisis that we have seen, that we continue to see in pediatric settings, including in pediatric hospitals. That's in addition, obviously, to the overall increase in the CHT next year. In fact, in a few weeks from now, the CHT will increase by 10%, another 6% next year, in addition to a minimum increase of 5% over the next 5 years.
Thank you, Minister. And the next question is, many doctors and nurses across Canada who cannot work in their field because they were trained abroad, but they want to work in their communities, even though they have strong experience. Can you expand on the steps our government has already taken towards implementing national credential recognition and other measures with the provinces and territories?
Very good. Thank you for that question. There's an obvious connection here between the people and the talent. We know that we need more people, more talents in Canada, and that's why the leadership of our colleagues and your own leadership when it comes to sustaining and encouraging stronger immigration flows into Canada. That's why that is so important. But when people come, they want to come and work quickly and use their talents and expertise to serve Canadians as quickly and as fast as possible. And that's why we want to enhance the ability of those credentials internationally obtained to be recognized quickly by provinces and territories. We also want national credentials to be recognized across Canada. And that's why great news is that with the efforts that collectively we've made over the last months, now we've seen significant movements, positive movements just a few weeks ago in Atlantic Canada, in all 4 Atlantic provinces. We're going to end up with regional licensure for physicians, which we can then hope to extend nationally. Other provinces like Ontario and British Columbia are moving very quickly in terms of recognizing the credentials of nurses and other healthcare professionals. This is great news because it's great news not only for the ability of those workers to be up to their full potential, but also for the ability of patients to receive the timely and critically important care that they need in many different settings.
Mr. Van Couverden, you've got 2 more minutes.
Thank you very much, Mr. Chair, and thank you, MP Sonia Sidhu, for allowing me to share your time today. Pardon me. Thank you for being here. To all of the witnesses, Minister, thank you for being here, and it's an honor and privilege to work with you as your parliamentary secretary. We all know that physical activity improves lives, improves health, improves physical and mental health, makes our communities stronger, but it also reduces the strain on our healthcare system if we have a healthier society. And recently we've seen some data from UNICEF indicating that children's health, a study that we've almost just completed, the rates are lower than we'd expect for a country with our considerable wealth and resources. So the promotion of physical activity is crucial, but also I think our government has a role to play in bridging the gap and reducing some barriers to access to physical activity, because it is medicine, it is preventative health care, and we talk a lot about health care and perhaps not enough about health. But as the Minister of Health, what can we do to not just promote physical activity, exercise, particularly for youth, but for all Canadians, and also reduce some of the barriers to access for that preventative health care measure? Thank you, Minister.
Thank you very much, Adam. It's, as you know, and I certainly want to say that openly, it's a great fortune that I've got, and many others also have, of working with you as Parliamentary Secretary, connecting your role as Parliamentary Secretary to sports to your role as Parliamentary Secretary to health. Not healthcare, because you're making a big difference between health and healthcare. The two are obviously connected, but there is no minister in Canada that is a minister of healthcare. There are 14 different ministers of health, not of healthcare. And that's because, as you've mentioned, prevention, among many other things, is key to well-being and health in Canada and elsewhere. I may open a brief parenthesis. Experts estimate that about 80% of health outcomes have nothing to do with healthcare, have everything to do with physical activity, healthy eating, having friends, being connected to the community, sleeping well, avoiding abuses, smoking as little as possible, not just being engaged physically, emotionally, and from a community perspective. That's what is driving most of the health outcomes. And as you've said, that is particularly true for children. And that's why, as you will know, as Parliamentary Secretary to Sports, and being such a leader and a driver of good health, habits, good physical and other habits. Now, the $20 million annual support to community-based initiatives that improve health behavior, including physical activity for populations at greater risk, including children in marginalized communities, children in indigenous communities, children in places where we know that it's even more important to focus on prevention, including physical activity. So thank you for your leadership, and thank you for pointing that out.
Thank you, Minister. Suite, c'est le tour du Bloc québécois.
For the Bloc québécois, Mr. Thériault, 6 minutes. Thank you, Mr. Chairman. And welcome, Minister. Do you know the percentage that is represented by the federal government's share in the 2023-2024 budget for Quebec health transfers? The historic percentage, not the historic percentage. Well, I was getting there. I don't have much time, though. The historic share is 35%, including tax points, and we're coming back to that. It isn't 35%, Minister. There is a budget. It's $59 billion in the government, in the Quebec government's charts yesterday. $8.60 billion is the federal government's share of that in health transfers alone. If you add transfers for post-secondary education and other social programs, $1.366 billion, we are barely at 16% as a federal government's share of health transfer. And we know that health services is not the entire transfer. The national average was 22%. You've added funding, you're calling it 24%. Why are we so far below the Canadian average? In many statistics, the 80 is the federal government's share of COVID-related spending. I'm talking about 2023-24, Minister. One moment, Minister. Mr. Thériault, the question lasted 1 minute. Then you interrupted the minister after the 10 seconds. Well, I'd like him to answer the question. Please go ahead, Minister. We often hear the figure 35% because we are effectively at 35% of provinces and territories' healthcare costs covered. If we include tax points this year and in upcoming years, we're back at 35%. 7 and 10% are the increases. The Canadian health transfer alone will go up by 10% in the next few weeks. And additionally, as you see in the budget, we're adding supplementary funding. So that is both a good impression of both short and long-term commitments by the federal government. So you're challenging the Quebec government's table showing changes in the federal government's share of healthcare funding as presented in the Quebec government's budget. You are talking about a universal healthcare system. That's how you present it. But when there are access problems, it is quite possible that some people may be obliged in emergencies to turn to private care. We've seen this, and it's not desirable. In Quebec, you're saying that 41 million is being provided, but your method is based on a poll where 10% of people responded, and you're transferring those figures, extrapolating them to Quebec. Do you think that is acceptable? The Canada Health Act is based on a number of principles. If I may conclude, accessibility and at no cost. Provinces and territories need to improve ways of providing access to essential health care, including diagnostics. That is their responsibility. Now, the principle of free access to such services is crucial under the Canada Health Act, and it is the Canadian government's and the federal health minister's obligation to impose deductions when people are forced to pay or can't pay and therefore don't have access to essential health care. What we've seen since 2018, some provinces like British Columbia have made some reforms. Do you have a specific analysis of what has been built in Quebec, or are you just extrapolating on the basis of 10% of respondents among several dozen clinics polled across Canada? Do you think that really is a good estimate, this 41 billion? Do you know how much one could do with that? These 41 million, you could carry out colonoscopies, make them much more widespread, and that is the second most significant killer. So don't you think that cutting these transfers by 41 million is seriously affecting people's health? We need money to look after people as things stand, given the current state of the system. These are good questions, Mr. Theriault, but if you want good answers, you need to give me time to answer. I'll try to be as quick as I can because you have every right to good answers, but I do need time to provide them. These amounts are drawn from cooperative work that we've been undertaking among departmental teams. British Columbia, for example, since 2018, is setting up reforms analogous to those that Quebec might be putting in place in the coming months, so that people who need essential diagnoses don't have to pay or aren't blocked from having them because they can't pay. That is an essential feature of healthcare across Canada. People need to receive the healthcare they need, and that includes essential diagnosis, and it shouldn't be tied to how much money they have. So we are proceeding in a collaborative and transparent way. Thank you, Minister.
Thank you, Minister, and all of your officials for being with us today. Minister, I want to pick up, I guess, where you just were. You, I think, very astutely acknowledged the federal government's responsibility to enforce the Canada Health Act. I agree with you very much on that. We know that for-profit clinics across Canada are currently charging desperate patients tens of thousands of dollars in some cases for two-tiered access to non-emergency surgeries. those clinics are exploiting a loophole in the Canada Health Act that allows people to pay to jump the queue as long as that surgery is performed in a province that they don't reside in. I don't think any of us think that's the way the Canada Health Act is supposed to work. Minister, will you act to close that cash for access loophole?
So it's a difficult but important conversation because we are in 2023. We need to take advantage of new ways of delivering care, including virtual care, including using the skills of workers that were not used earlier to provide essential services like nurse practitioners and physician assistants. This is great news. Provinces and territories should and can do that. At the same time, as you're pointing to, we need to ensure that these essential services, healthcare services, are provided free of charge. Otherwise, as you also mentioned, there are some people that won't be able to access these services, or they will have to wait until others are able to access those services based on a two-tier, two-speed system. And this is not what we want to have in Canada. A two-speed system is not what aligns with our values of equity and solidarity and efficiency, including from a public health care perspective. And that's why we are therefore going to continue, as you've seen and as you're supportive of, continue the important work that we need to do with provinces and territories over the next weeks, months, and years.
Thanks, Minister. Minister, nearly a quarter of Canadians report going hungry due to cost, and 2 million children are at risk of going to school hungry across country. In the last election, both the Liberal Party and the NDP pledged to invest $1 billion starting in 2022-2023 to establish a national school nutritious meal program to ensure that no child is forced to struggle through the day on an empty stomach. Minister, you've wisely identified the importance of social determinants of health. Given that this is an important preventative health measure and that commitment has not been fulfilled to date, can you confirm if that funding will be included in the upcoming budget?
Well, I can confirm, and I'll say the other thing after, is that I confirm exactly what you're saying. Prevention, as we were mentioning just earlier, especially for children, is absolutely essential in a key health care and health determinant. And that includes healthy eating, and not only from a health physical perspective, but a mental health perspective, the ability to learn and to develop the child's full potential over time. And that is why we have committed to building a national food program that is under the leadership of Minister Gould and Minister Bibeau. They know really well, and you will want to have a conversation with them.
Sorry, Minister, I'm going to interrupt. We're about the same amount of time. I'm not hearing a clear answer to that. I think we'd appreciate one if you could give one to the committee. In 2021, former Health Minister Patty Hajdu told Canadians that a, quote, full investigation, end quote, into Canada's COVID-19 response would be required at the, quote, appropriate time. She said, we're still in a crisis, and so our focus remains right now on getting Canadians through that crisis. But when the time is right, our government will be very open to examining very thoroughly the response of this country to the COVID-19 crisis. Minister, in September 2022, you noted that a government decision could come, quote, soon on what kind of review should be held, but your government has yet to take action in the 6 months that have passed since you made that comment. We're clearly out of the crisis. Will you make a firm commitment today to launching an independent public inquiry into the federal government's COVID-19 response?
A couple of pieces to that important question. First, as we know, there have been a number of different studies on our reaction and our collaboration for COVID-19, including several reports from the Auditor General, including significant internal collaborative studies within the federal government and between the federal government and other governments, and that it also involve, obviously, public health agencies. I have had personally a large number of meetings with stakeholders, experts from different communities, and have invited them to keep providing us with their input into that reaction. We are currently discussing a bill in the House which is pointing to that as well, the importance of having a review of COVID-19. And finally, we need to do this in two ways. First, it has to be inclusive of all perspectives, and B, it has to be inclusive of all aspects of that
Thanks, Minister.
That work.
I think my question was on an independent public inquiry, and so even that, if you have further thoughts on that, you could please indicate that to the committee. Minister, I don't have much time left. Given that alcohol has recently been noted by the health department as a carcinogen that can cause at least 7 types of cancer. Why aren't alcohol containers required to carry warning labels in Canada like tobacco products?
That's a great question, and in fact, we have Dr. New with us today, who is, as you all know, a public health expert. So there is the data piece, the epidemiological, the clinical piece of that, and I would invite you, perhaps, Dr. New, if you could, in a short amount of time, just to provide your reactions to what you just heard.
Well, I would say in terms of the alcohol, and everyone's aware of the new sort of alcohol drinking guidelines. I think it's been, something long awaited, because certainly in terms of what I think the average Canadian thinks has been, quote, up to now, a, quote, a safe or acceptable drinking sort of limit in terms of number of drinks per week. Certainly, I think it's been sobering, if that's the right term to use, even for myself in terms of what it is. So I would say that, yes, the evidence is there that, Canadians need to make informed choices for themselves. I think it's important to have the information. It is a lifestyle issue, but there are also some other aspects to consider beyond the sort of the pure point about, the risk of various diseases. Some people talk about some of the social benefits and so on, and that's all part of the equation. I think as we move forward as a country and as individuals, I think we recognize that everything in moderation is probably the way to go. So I would say that, in terms of the specific aspect, yes, the evidence is there that it is a potential carcinogen for lots of different types of cancers. But in terms of the next step forward from a regulatory perspective, I would defer to my regulatory colleagues in that regard.
Thank you, Dr. New. Next, Ms. Goodrich, please, for 5 minutes.
I find that quite ironic that you're talking about limiting alcohol while your government is also providing free drugs to people struggling with addiction and saying that that's supposedly safe supply. The irony is pretty rich. But I'm going to shift gears to something that's been really pressing, and it's in the news a lot lately, in regards to baby formula. And so really simply, how much baby formula is produced in Canada?
Well, thank you for pointing to that, Ms. Goodrich. We did talk about this personally in the last days and weeks, and I want to thank you and congratulate you for your leadership on that. As a young mother and as a parent, certainly myself, we know and feel the stress and sometimes the distress that comes with not having access to essential infant formula in the formulations, in the sizes.
Minister, how much is produced in Canada?
We don't produce any in Canada, and that's why this is a challenging file, and that's why we have been working with... So
is there any spending in the estimates to increase domestic production of baby formula?
Point of order, Mr. Chair. We really want to listen to answer from the minister too.
I'm doing the same.
Yep.
On
No,
times.
Ms. Goodrich is entirely within her rights. It was a very short question. She's entitled to a short answer, and I think the big thing here, out of respect for the interpreters, is that we try not to talk over one another, but bear in mind to the witnesses that we've done pretty well in terms of members keeping their questions at about the same length as the answers, so we would ask you to do the same. Ms. Goodrich, you won't lose time for that intervention. Go right ahead.
So is there any specific spending in these estimates to increase the domestic supply and production of baby formula?
That's why what we're doing is a number of different things. Yes, we're going to encourage and support whatever ability we have to produce domestically infant formula, because the challenge that we have now is that outside, since we depend entirely on foreign production, when there are plant breakages or recalls of formulas,
Minister,
we are impacted severely by
Ms.
these
Goodrich,
external factors.
Thank you. So how much is being spent in these estimates to increase the domestic production of baby formula?
And that's why, in addition to what I just said, what we've done, and Dr. Sharma can expand on that, is to use an interim policy which has brought in 70 additional different formulas.
I'm asking a specific amount of money being spent. Is there any money being spent?
I can answer that directly, and but I will turn for that to Dr. Sharma. But as I said, we are and Dr. Sharma can provide the right level of details, which you are rightly asking for.
Minister, it's really frustrating. I'm asking really simple, really direct questions. I'm not having a big preamble here. I don't understand. If there is money being spent, how much? If there isn't money being spent, just admit it to Canadians. Parents deserve to have these answers.
Let's turn to Dr. Sharma. This is a totally appropriate question, and we'll ask Dr. Sharma to make it more precise what the department is doing to accelerate and to simplify the delivery of infant formula to Canadian families.
Thank you. I mean, the direct answer is there isn't dedicated funding for it at this time because we're actually working with other departments, including ISED. And I'll just add that, currently in Canada we have over 150 formulas that are approved and another 70 that were brought in temporarily. So in terms of which formulas might be useful, to have manufacture in Canada, it's still discussed. But also we're having there is one company in Canada that has provided a submission to Health Canada.
It's just disappointing. We've been in a massive shortage of baby formula for more than a year. Parents are struggling. Families are going from store to store to store just to try and find baby formulas so they can feed the most vulnerable people in our society. And these are parents that often don't have a choice. There is not some other option to feed their child. And the Government of Canada doesn't have any spending in the estimates whatsoever, despite this being a massive crisis, to have more baby formula produced here so that we're not dependent on foreign supply chains. This is absolute lunacy.
150 and 70 are the two numbers we just heard. So 150 different formulas have been brought in Canada, and 70 additional formulas have been brought into Canada because of the work of Health Canada. This being said, this is a very challenging, stressing situation for lots of families, children, including mothers, obviously, across Canada. This is going to last for another couple of weeks. No, we're not going to
weeks? So you can assure us that we will have
weeks
more...
and possibly months, because we can't control foreign production, unless we were to send,
So then why not invest in domestic production for baby formula?
And that's why this is one of the things that we need to do. And the additional thing in the short term, because we can't wait until a domestic plant is created, in the short term we'll keep bringing in additional formulas, exports from Europe and other places in the world.
So are you committing that you will be spending money to increase domestic production of baby formula with Canada's world-class milk industry being used?
So what we are going to do is to do the two things. First, we're going to invest in the short term to try to resolve this crisis, which is entirely driven by issues of foreign production. And that's therefore why it has to be through exports, expediting exports, which we have done, but which we need to do even more in the next weeks and months, because we know that this crisis is going to be there for some time. And the second thing, which we have done with vaccine production, research and development of treatments for COVID, PPE, and so many other things in the last years, quite successfully, not perfectly, but quite successfully.
I guess I'm not going to get
an answer,
and I think I'm out of time.
And other products essential for Canadian families.
You have one more question, Ms. Goodrich. Go ahead.
I think it's sad, and I just want to put it on the record. I'm asking very simply if there was spending for increasing domestic production. The answer was no. I asked if there was domestic production. The answer was no. So what exporting product, but we're not finding it on the shelves, that doesn't really help families that are struggling today, and it's not planning for the future for the families that are inevitably going to be struggling going forward.
What is going to help in the short term is to keep expediting, through the regulatory work that the department is doing, the ability for families to receive important infant formula. That's going to be what matters in the next weeks and months. Eventually, in the next years, hopefully we'll have domestic production of that infant formula. We can't wait for the next year for that to happen. That's why the resources that we're investing in the regulatory work of Health Canada is so important in the weeks and months to come.
Dr. Pawlowski, please, for 5 minutes.
Good morning. Do you hear me? I wasn't sure if my mic's working. Is it okay?
Yep. Seems good.
Okay. So I don't know about you all, but I'm really happy to be meeting with the minister and the department. The first time in 3 years, not talking a lot about COVID, which is tremendous. Things are getting better, but as Dawn pointed out, as things get better, I think it's incumbent upon us to think of the future and the possibility of something like COVID reoccurring. And certainly part of the process, and I think all levels of government have to look to what happened with COVID and see how we could do better next time. But certainly at the global level, we have to review what we can do in order to be able to faster detect outbreaks of these disease and to respond to these. So with that in mind, Minister Duclos, you and I were at a meeting of stakeholders the other day to talk to various experts to inform Canada's position in the ongoing negotiations of a new treaty on infectious disease that WHO is carrying out. So maybe you could talk a bit about that treaty, the importance of that treaty, but also about how your department is engaging the public, as was the case with that meeting, in terms of helping to inform our position in the negotiations. And lastly, I know you've hired quite a number of people, including global experts like Stephen Hoffman, who's an acknowledged leader globally in global health law, to be part of our team in negotiating the treaty. Could you talk a little bit about some of those new hires, perhaps? Thanks. And you're welcome to use any of your department officials in responding.
Good. So please stand ready, Dr. New. First, let us acknowledge that this pandemic has been a global pandemic. And being a global pandemic, it required, and future pandemics will require global actions and reactions, including a better flow at the global level of information on the nature of the viruses or whatever other sources of pathogens there may be, the epidemiology and the possible treatments, diagnostics. So this is all global science. In addition to being global science, it also is a set of global reactions that matters so much. And that's why, Marcus, I want to thank you for being at the center of this exercise, trying to make it better for the world to collaborate and to exchange information in the future pandemics, because we know there will be more. Climate change, the loss of forest, the globalization, the movements of people. This is all increasing the probability and the intensity of future pandemics. So the WHO's work and the treaty, which requires significant, obviously, international collaboration, is key in saving and protecting millions of lives. The estimates suggest that because countries were able to work together, more than 20 million lives in the world would have been saved, including hundreds of thousands here in Canada. Now, these are many people whose lives have been saved or in larger numbers have been protected because of international collaboration and domestic actions. Now, when it comes to what more we need to do at the world stage, if that is fine, I could turn to you, Dr. New.
Yes, merci beaucoup, Monsieur le Ministre. What the Minister has said, that certainly as a country we're very engaged. We're looking forward to obviously contributing to this very important, I think, process and negotiations at WHO for. I think you're referring to the pandemic instrument. What I would say is that, as you alluded to in terms of expertise and how we're engaging, I would say that certainly, as you alluded to, Dr. Hoffman, myself, lots of other, I think, internal experts here within the health portfolio are going to be part of that process. But in addition, we're looking forward to obviously engaging with the stakeholders across the country. For example, yesterday there was a forum that was held, and I had a session with the chief medical officers of health. So in terms of the public health community, at least, that was a very important first step in terms of bringing everyone up to speed and also sort of laying the path forward. This is going to obviously unfold over the coming months, and so it's important that we continue to engage with public health experts across the country, academics, civil society, and so on, to make sure that we really put forward, our best foot as a country.
Thank you, Dr. New. Dr. Poloski, Monsieur Thériault pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. Minister, will you admit that the method you used to take money back from Quebec was very approximate it was primarily cooperative, Mr. Thériault, because all the data make sense when they're shared among levels of government. That is why over the past 5 years, officials in both our governments worked together, as Mr. Dubé keeps saying. Minister, I have only 2.5 minutes. Do you know what a letter of agreement 108 is? It is a letter that is signed with the private sector. The Quebec government signed agreements with its clinics, and since your methods are not precise, what you have been clawing back already as an amount has been corrected. Are you going to give Quebec that money back? We know that the private sector must play a role, and in fact does, in improving access to health care across Canada. Secondly, we can collect data more easily when we work with the private sector. That's why we invite officials and experts to exchange data, because we have not only the best estimates but the best responses. Why did you use such imprecise methods, and why did you not check with Quebec when it came to a real analysis of the situation? I'm going to turn to the Deputy Minister. No, I'm putting the question to you, Minister. I'll have hours with the officials. You signed the press release. You are not investing the amounts that were required for the medium and long term. And to add insult to injury, you're getting your figures through very imprecise methods, 41.868 million, and you don't know really how you got that number. Are you going to be checking those figures in the next few days? What we need to check is to make sure that people don't need to pay for essential diagnostic services in cases of cancer, chronic disease, diagnoses that are essential for people to get the right treatments. There are lives at stake when people cannot get diagnostic services. So we need those to then have the right treatments for them. Thank you, Minister.
Will be from Mr. Davies for the next 2.5 minutes.
Thank you, Mr. Chair. I have 3 questions. Minister, I'm going to ask you to please keep your answers to the time that I asked them in. Minister, Canadians pay the 3rd highest prices for prescription drugs in the world. The Liberal government has promised to reduce these prices since they were elected in 2015. Can you tell us if prices have come down since then?
I'll turn to that because this is both an important question and a question that requires a clear answer. So first on the issue which matters the most, as you said, we pay in Canada prices that are excessively high. The prices of patented medicine are just below those in
Minister,
what we
with
find
respect, I have 10 seconds left. I just asked if they've come down or not.
Now, as we know, and I can turn to officials, there are thousands of different prices.
Overall, have they come down?
I can turn to whoever is the expert around the table to provide the mean estimate, but that mean estimate may be misleading because there are so many different types of products.
I'm sorry, we're out of time for that question. I'm going to move to my next one. Minister, can you confirm if the patented pharmaceutical industry is currently in compliance with its commitment to spend 10% of its sales on research and development in Canada?
My understanding is that this is not the case, and that's why we need to have the industry invest more in research and development and production of these essential drugs in Canada.
Do you know what the percentage is?
It has changed over the years, but it's certainly not to the level where it should be.
Thank you. Finally, in 2019, the Liberal government, your government, appointed the Hoskins Advisory Council to study pharmacare, and they recommended that your government implement a single-payer, universal pharmacare system by enacting new standalone legislation embodying the 5 principles in the Canada Health Act. Minister, can you confirm if the Canada Pharmacare Act that your government has committed to passing this year will adhere to Dr. Hoskins' recommendations?
What we will do, and that is exactly what we committed to, and I believe many members in this committee and in the House will be supportive of that, is to introduce an act, a Pharmacare Act in 2023, which will have 3 objectives. First, increase accessibility to essential drugs. B, increase affordability to these drugs. And C, make sure that the drugs are safe and effective. And it's at the basis of these three principles that we look forward to having this bill being tabled.
Thank you.
Thank you, Mr. Davies. Thank you, Minister Duclos, and your panel of esteemed officials and advisors. I realize that the format is difficult. I appreciate your patience. We're trying to do our best to make sure that everyone gets to pose their questions, and I know it isn't always easy, but thank you so much for being here, and thank you for what you do for Canadians and for us. Ms. Goodrich.
We started late,
No, we didn't. We started at precisely 11 o'clock.
and we're now ending 5 minutes early.
We are ending so that we can suspend to allow the next panel to get in here and also have 55 minutes. Thank you very much. You're welcome to stay, but you're free to leave. The meeting is suspended for about 3 minutes to allow for the next panel to take their place. We'll save it for afterwards, Minister. I call the meeting back to order. For the second panel, please allow me to welcome the Honourable Carolyn Bennett, Minister of Mental Health and Addictions and Associate Minister of Health. In addition to the officials that were with us during the first hour, she is joined by Eric Belair, Assistant Deputy Minister to Strategic Policy Branch of the Department of Health, and Shannon Nix, Assistant Deputy Minister, Cannabis and Controlled Substances Branch, and from the Public Health Agency of Canada, Candace Saint-Aubin, Vice President, Health Promotion and Chronic Disease Prevention Branch, joining us, I believe, by video conference, or is she here in person? I put my glasses on here. I guess she's here by video conference, or expected to be. Thank you all for taking the time to appear today. We're going to begin with opening remarks from Minister Bennett. You have the floor for 5 minutes. Welcome to the committee, Minister.
Thank you very much, Mr. Chair. Monsieur le Président.
Mr. Chairman, honourable members, ladies and gentlemen, thank you for giving me the opportunity to appear before the committee today. I would like to begin by acknowledging that we are on the unceded traditional territory of the Algonquin and Anishinaabe people, who have been stewards of this land and water since time immemorial.
Very grateful for the full team, Mr. Chair, that you introduced, but I did want to just highlight for the members here that to my left, Heather Jeffries was once the Associate Minister on this side and is now the President of the Public Health Agency of Canada, and so we just want to give her congratulations on that new big job. So, le ministre Duclos.
Minister Duclos has already given an overview of the funds we are requesting through the supplementary estimates C and the main estimates, and I would like to explain how our resourcing plans will improve and expand health and substance use support services for Canadians.
As the Minister said, and as all of us know, Canadians have to be able to access timely, evidence-based, culturally appropriate, and trauma-informed mental health and substance use services to support their well-being wherever they live. We've made significant investments since forming government to support this, including the $5 billion over 10 years, beginning in 2017, to expand mental health and substance use services through the direct bilateral agreements with provinces and territories. There was also almost $600 million for distinctions-based mental health strategy for Indigenous peoples, $270 million to support the Wellness Together portal, as well as a number of other key investments to support the mental health and substance use of Canadians. We all know that there is more to do and believe that mental health has to be an integral and integrated part of Canada's public health care system, as it was in the Canada Health Act. Physical and mental health. We also are fulfilling a commitment to transfer billions of additional dollars to the provinces and territories over the coming years to support mental health and substance use through the combination of both increasing the Canada Health Transfer and through the new $25 billion for a 10-year FPT bilateral agreements. All premiers agreed to move forward with this federal investment, and mental health and substance use is one of the 4 shared priorities in the new bilateral agreements and is also integrated into the other 3, family health services, the health workforce, as well as the data and digital tools. The new FPT bilateral agreements will include an integrated, inclusive approach to mental health and will require the provinces and territories to produce detailed action plans with indicators and metrics. This approach is the most effective way to integrate mental health and substance use services throughout the healthcare system, including primary care, and to ensure the transparency and accountability from the provinces and territories about how this funding is spent to their citizens. We also know that the toxic drug and overdose crisis continues to take a tragic toll on the families, loved ones, and communities. Since 2017, we have committed more than $800 million to address the overdose crisis, and we are taking concrete steps to divert people with substance use issues away from the criminal justice system. Approving BC's decriminalization proposal for personal possession of certain substances was an important step. And its January 31st coming into force includes the monitoring both the public health and public safety aspects of this complex issue. Harm reduction measures save lives, and safe consumption sites have reversed over 43,000 overdoses since 2017. Our government has invested over $88 million to expand access to safer supply of pharmaceutical-grade drugs and increase to life-saving naloxone across the country. We will use every tool at our disposal to combat this public health crisis, including working with British Columbia since 2018 on the litigation on behalf of all Canadian governments against Big Pharma to ensure they pay for the problem they created. Canada has also restricted the marketing of opioids and increased the maximum financial penalties to combat the predatory practices of pharmaceutical companies. I look forward to expanding on my brief remarks through your thoughtful questions.
Thank you, Dr. Bennett. We're going to begin with questions now, starting with the Conservatives. Dr. Kitchen, please, for 6 minutes.
Thank you, Mr. Chair, and thank you, Minister, for being here. My questions to you are going to be more in your role as Associate Minister of Health. I'm sure you're aware that the Public Health Agency of Canada was started in 2004 as a proactive agency to deal with emergency preparedness, infectious disease, chronic disease, and control and prevention. Not to mention the National Microbiology Lab, as well as GIFIN, which eventually was shut down in 2019. But one other aspect of it is the NES. And basically, we've known that the National Emergency Strategic Stockpile was plagued at the issues of the onset of COVID-19 pandemic by government mismanagement. One warehouse was shut down in Regina and threw out 2 million masks, N95 masks, and 440,000 medical gloves. My question to you is, has the nest been fully restocked at this time?
Yes, thank you for the question, and absolutely, I think that we can answer that question. I had a great conversation with Minister Blair this week about his visit to the nest and how important it is that we keep that replenished and with the products that will not be outdated and that will be accessible for any future.
Thank you, Ms. So I'm taking that as a yes, it has been restocked. Is that correct? And how much money has been spent on restocking it?
I'll let Heather answer that.
So the NES has been expanded greatly as a result of the response to the COVID pandemic, sourcing the specific supplies needed to respond to COVID in addition to the traditional stockpiles that it's always maintained. It is fully stocked with COVID-specific therapeutics, with medical countermeasures, ventilators, the kinds of personal protective gear and equipment, and a large majority of those supplies have been procured domestically now within Canada as our domestic manufacturing has increased. So I would say that the expansion in warehouses and supplies in accordance with the needs also goes along with a more sophisticated management system, including IT, inventory management, and just-in-time delivery and logistics.
I did not hear a cost of how much was spent.
I do not have the total figure for that number, but I can.
Can you provide that for us, please?
I can provide it to the committee.
Thank you. Furthermore, a 2021 report by the Auditor General recommends that Canada should develop and implement a comprehensive NES management plan with clear timelines that responds to relevant federal stockpile recommendations made in previous audits and lessons learned from the pandemic. PHAC agreed with this, stating that the agency is expecting to complete the management plan with clear timelines for implementation within 1 year of the end of the pandemic. I've searched high and low for this plan, cannot find it. My staff has searched high and low, cannot find it. The question really is it available? And then with that, does this, I mean, is it such that PHAC is waiting for the World Health Organization to declare that the pandemic is over before implementing such a plan?
So there is indeed a plan. We have been working in real time, incorporating the lessons learned from the COVID response as we've gone along in pandemic response. That includes some of the information management, information technology that I was speaking about earlier. It includes a risk management approach to ensuring we have the appropriate stockpiles. We have not waited while we continue to respond to the pandemic, and vaccines and countermeasures and equipment continue to be deployed in real time to those who need it, including internationally for key partners such as in Ukraine and elsewhere where shortages continue to occur. We are working and with the plan that has been developed and are responding fully to all of the recommendations in the audit report.
So again, is the plan available for public consumption?
We can provide the lessons learned that have been implemented and the approach to that we are taking to restock the NES and to...
Lessons learned does not show us a plan. The Auditor General clearly stated that the plan would be developed. The Auditor General not only presented that report to PHAC, but PHAC said it would put it out within a year. Can we see that plan, please?
The plan that would be published in response to the Auditor General's report, as you mentioned, is within a year of the end of the pandemic, and we continue to be responding to the pandemic as we speak.
So there's no plan. And we have no plan for an emergency organization. The reality is emergencies are going to be happening. They do happen. Just like COVID came out of the blue, emergencies come up. The whole purpose of PHAC is to be proactive and doing tests and beforehand to make certain that we're prepared for when those emergencies happen. Therefore, the Auditor General has clearly pointed it out. You have indicated that there's a need for that. Why do we not have that plan today?
I would say, Mr. Chair, respectfully, that we do indeed have a pandemic preparedness plan. It includes the NES, it includes its organization, its management, and its stocks. Those plans have been updated in accordance with the new lessons that we've learned throughout this pandemic, and they are being implemented in real time. We have put in place additional inventory management software. We've procured stocks. We've worked on domestic supply. And the NES is very well functioning and delivering in real time to provinces. And the Auditor General's report has been very favorable in that regard.
Thank you, Ms. Jeffrey. Mr. Johari, please, for 6 minutes.
Thank you, Mr. Chair. And Minister, welcome to our committee officials as well. Some of you have been with us since 11 o'clock this morning. It's good to see you, Minister. Minister, in your opening remarks, you talked about the historic investment that our government has made in healthcare, specifically mental health, a number of times. In 2017, specifically, we allocated $5 billion. I'm glad to be part of the advocacy group who managed to facilitate that. However, this year, with the $198.6 billion investment over 10 years, I think we are hitting another milestone in our investment. The four pillars that you talked about and the integration of mental health to each one of those pillars, whether it was data, whether it was parity in providing the help, and whether it is outstanding. Minister, this year the budget included about $48 billion more in spending. Can you decouple the part of the mental health services that extra money is going to bring in?
So as you know, that by increasing the Canada Health transfer to almost $200 billion, that allows the provinces and territories to really focus on treatment and their delivery of health care. Where the $25 billion will go in the bilateral agreements with provinces and territories, that it means that everyone has an attachment to a primary care team with adequate mental health and substance support. on the HHR, on having adequate health human resources without burnout, being able to maintain retention. That means there has to be appropriate mental health supports and substance use supports there to keep a robust health workforce. On the third category, which mental health and substance use, we're hoping all members of Parliament and as well the provinces and territories and the stakeholders working on the ground will develop the kind of indicators to make sure that there will be that we will be measuring as we go, and there will be that accountability and transparency that is more than just wait times or unmet mental health needs from the Canadian Health Survey. And then in the last section, it will be on the data and the ability to see in real time what's happening, transfer the kind of records, having citizens have access to their own record, particularly important in mental health, where mistakes can be made and where we don't want any more people's intimate mental health records being in offices with fax machines anymore. This has to be privacy delivered, but it is a I think a very exciting time for the transformation of health and healthcare that some of us have been fighting for 30 years. Doctor to interdisciplinary, hospital to community, patient at the center of their care with the systems wrapped around them, as opposed to people having to fit into a system that doesn't work for them, and then for us to have the accurate data and evidence to be able to do what works and stop doing what doesn't work.
Thank you. You covered a number of points, Minister. You are touched on the $25 billion around that's spread over 10 years around shared priorities, and thank you for highlighting the aspect of the mental health. And you also touched on the area of KPIs and key indicators. One of the challenges we saw back in 2017 was around the fact that we actually did not have any KPIs. And it is very hard for us to be able to correlate the investment, the historical investment we made, to the actual delivery and improvement of the services. Can you talk about the part of the accountability and transparency that it's much desired? I have 5 community council, one of them is around health, yes. And they specifically highlighted the fact that we really need to hold all levels of government accountable for that. If you could touch on that, I'd really appreciate it.
Thank you for the question, and also thank you for your leadership. I think the work that you did on the handbook for parliamentarians on the mental health and mental health literacy is hugely important to all of us and our teams, and it's been an example to so many stakeholder organizations as to make sure we're using the right terms when we're talking about mental health and mental illness, knowing the difference. So thank you for that. But in the 6 priorities that were identified in 2017, I think that we know some great work's been done on the integrated youth services across the country, and all 10 provinces, the 3 territories are really working on getting those young people 12 to 25 the kind of wraparound services they need, from peer counseling, primary care, right up to social work, psychology. It has been really impressive. On increasing mental health supports in primary care, we're getting somewhere, Hamilton, other places. In digital health and being able to have your mental health visit virtually has been helpful. Mental health supports and services, mental health HHR. But last week in Kelowna and Penticton, it was very interesting that the area that the municipalities are feeling is that we're not doing well enough is on the complex care that was the 6th priority. People who have serious mental illness and substance use are the people most in contact with the justice system and the most frequent in the emergency department. If we could get in some of these communities, those 20 people properly housed and with the wraparound services, this would be a huge focus, I think, for so many of the communities that I've been visiting.
Thank you.
Thank you, Minister. Suite, Monsieur Thériault, pour 6 minutes, s'il vous plaît.
Mr. Thériault, 6 minutes, please. I have a question on the announcement of $1.5 billion for rare diseases. What I asked last time was this. When we have to deal with a disease like ALS, the approval process that goes to as far as patient reimbursement is very long. ALS gives you 3 to 5 years of life. This is medication that could extend life. Have you provided for or envisaged some rigorous mechanisms that would be helpful in the case of rare diseases, for example? Yes, I will ask Eric Belair to answer. There was significant emphasis on improving access to medications for rare diseases. As you saw, over 86% of that budget will be transferred to provinces to strengthen their coverage. In addition to increased access, there's also the issue of ensuring that agencies who make decisions on easier access can work together so that patients can get more timely care. That includes agile regulations to be introduced in December, which will make it easier to have some drugs certified even with fewer data, since they do target much smaller patient populations. They will be certified, authorized, and then more data will be collected subsequently. This is being done in cooperation with the agency assessing health technologies to make it possible for provinces and territories to have the needed data to cover the drugs. So there are some parallel studies going on between the regulatory agencies and health assessment authorities so that the total time taken to provide patients with access is shorter. These studies are done at the same time. There's also the provincial negotiations for drug prices. We're making every effort to make sure that all players in the decision-making process make their processes more effective. My other question is on dental health coverage. The Parliamentary Budget Officer is concerned about control measures and is concerned about fraud, since reimbursements are not done on presentations of receipts. Why was this program put in place so precipitately? Mr. Chairman, I will answer the member. First of all, the government introduced and Parliament passed an interim benefit. The Canada Revenue Agency has measures to strengthen alignment by means of a compliance and enforcement system to check the receipts of a certain percentage of people. This is an interim program. Yes, it is an interim program. However, it's part of the same health envelope that everyone has. So we don't have a single cent to waste. Services have to be provided, and we need to ensure that the $650 that is being sent, because it's needed by some young people, isn't being sent for nothing. When we waste money in one area, that money is not available elsewhere. So has the government gone ahead so precipitately? I'm not saying this, the Parliamentary Budget Officer does. Did you provide the government with advice to the effect that this might lead to fraud, as we saw with the emergency benefit with CERB, but do we need to waste money because it's an interim program? The CRA has tools to check information provided by taxpayers, and it has compliance and control tools. It has also drawn lessons from other programs during the pandemic to prevent risk. The Parliamentary Budget Officer states that in the Act, no systematic verification measures are provided for. And that's not so, Mr. Chairman. There is a systematic auditing program at CRA, so we'll tell the PBO this. I believe that the incentive for parents to take their children to the dentist is really so important in prevention. It is a priority in the area of prevention. That's all the time you have, Mr. Thériault.
So welcome back, Mr. Johns.
Minister, for being here, and to all the public servants that are serving our country, and especially health officials. We really appreciate the work that you're doing. Minister, will the Canada mental health transfer that you promised to Canadians, and it's in your mandate letter, be in the budget next week?
Thank you, Gordon. Thank you for continuing to push the need for resources for mental health and substance use. I think in my opening remarks, I was clear that what has been established is that the more effective way of delivering excellent, appropriate mental health and substance use care is by integrating it into primary care, into the support for health human resources with freestanding mental health programs and substance use, as well as in the data. So we will see in that $25 billion that there will be dedicated dollars. All of the provinces and territories have established mental health as a priority.
Okay, I've got some questions around that.
And we will work with them on their action plans with indicators as well as targets, as well as be able to make sure that in that elevated Canadian health transfer, that they will have more money for treatment in
so
their
that's
provincial
a no
budgets.
then in terms of the direct transfer. But we know that Canada spends, a woefully low amount on mental health and substance use, in regards to healthcare, below most of our G7 and OECD partners, and it shows. In the absence of the Canada mental health transfer, can you guarantee then that the provinces and territories will allocate funds to mental health and substance use under the bilateral health agreements to the amount of 12%, which is around what our G7 and OECD partners are spending?
I think that Eric and I should have introduced both Shannon from the.
I wish we had time to do a big introduction, but I'm just asking, will we be at 12%?
Well, in each of the action plans with each of the provinces and territories, we know mental health and substance use is a priority, and we will be working with them on adequate action plans to make sure that mental health and substance use is part of each of the
what oversight are we going to have?
priorities.
What oversight are we going to have as Parliament over the bilateral health agreements? Will stakeholders and people with lived experience of mental health and substance use health concerns be consulted in the development of action plans? What are we going to be? When are we going to know what's in those agreements? Because you've said $25 billion over 10 years. That's $2.5 billion a year in 4 priority areas. How are we going to know how much is going to mental health and when?
Well, that, I think, is what's exciting about this new approach, which is that the action plans will have all of your stakeholders can really try and influence the kind of indicators. What should be measured? What's a reasonable target? How do we influence not only the federal government, provincial governments, in making sure those action plans are clear? Because the action plans aren't reporting to us or even to parliamentarians. They're reporting to their citizens.
They need to report
and that
to
actually, it needs to be transparent and accountable, and that's where we're going. They must post the action plan.
Okay, so Minister, our job is to hold you accountable.
Thank you, Minister. Thank you, Minister. Go ahead, Mr. Thank you,
Canadian
Minister.
Institutes of Health Information are helping with those indicators.
Thank you, Minister. We're trying to keep the answers the same length as the questions. Go ahead, Mr. Johnson.
We're prepared to step in and fill gaps created by provinces and territories that failed to put these dollars to mental health and substance use. Are you willing to do that?
I think what is these action plans will be negotiated with provinces and territories. That means that the priority areas, the indicators, the targets will all be an agreement between the federal government and the province. We are insisting that mental health and substance use be part of each one, and then they will have to make that action plan transparent to their citizens, and they will be accountable to their citizens.
I'm worried about transparency to parliamentarians, because our job is to hold you to account, Minister, to make sure that the money's actually flowing to the communities. So I'm concerned because I'm not getting answers around that. Now, community mental health services, harm reduction, supports, counseling, psychotherapy, and other services, we know it remains out of reach at millions of Canadians. Will we see meaningful investments specifically in these areas in the budget next week? And I want to just read a quick email I got from a constituent of mine. He wrote, our adult son, unfortunately, has become addicted to fentanyl. We have him in a treatment center. It's very expensive. We borrowed money from a family member to finance his recovery. We may have to sell his house to pay for it. And he asked if there's any financial help that might be available to him. We know the answer, no. If his son broke his neck, he'd be getting covered. The universal health care system doesn't protect him. What do you have to say to his father? We know Portugal, they went on a renaissance, developing treatment on demand so that they truly had a universal health care system. When will we have parity with mental and physical health in this country? What do you have to say to this son's father? When are we going to have treatment for this young man? What a decision he has to make, whether he's going to save his son's life or abandon him.
And so as we go forward, I agree. We actually have to get mental health and substance use treatment back in under the publicly funded system.
It needs to be
It was in the
immediate.
Canada Health Act that way, and now with cost containment in the 80s and 90s, it moved out to the private sector, moved out to the charitable sector. We've got to get it back in. That's why having mental health and substance use as part of primary care teams, as having separate dollars that provinces and territories will be able to spend on the pathway to recovery. But we also need to make sure that people who've been in treatment have the aftercare, so they're not a revolving door back through. And so that's why having a really integrated system is going to work. And I couldn't agree with you more that people should not have to pay for that.
Thank you, Minister. Ms. Goodrich, please, for 5 minutes.
Thank you, Mr. Chair. I'm going to ask very short questions, and I will ask that you respect and give short answers. Very simply, I've talked to tons of people in recovery who told me that when they were in active addiction, they didn't want safe drugs, they wanted good drugs. And they would trade any prescription or good, safe drugs they had to get better drugs. And they say that safe supply is an absolutely bad idea that will make the problem worse. What do you say to these people?
I'm saying that 40 years ago, people said the same thing about methadone. 20 years ago, people said the same thing about Suboxone. That we are moving, and more recently, things like hydromorphone, Dilaudid. There are very good stories of people being able to get off fentanyl by Dilaudid, by other diacetylmorphine that I saw in...
Thank you, Minister. So pharmaceutical companies like Purdue were sued and doctors went to jail for their role in causing the opioid addiction crisis. What will happen should pharmaceutical companies and doctors that are potentially will be causing harm with this so-called safe supply, will the same thing be happening 10 or 20 years from now?
Absolutely, and that's what the colleges of physicians and surgeons are doing. That's what the colleges of pharmacies are doing. But I wanted to say, in that anecdote about that, in the clients that I saw last week in Kelowna, who were getting injectable diacetylmorphine, it is not possible to divert that, and so we actually have to do what it takes to keep people alive long enough to get to recovery.
So to just shift gears a little bit, what evidence is available on the impact of legalization of recreational use of cannabis on health?
This is an ongoing study. I think that as we've talked before, the use of cannabis in youth has not gone up, and that we are being able to see that for seniors and others, that is being helpful.
Minister, when will there be a legislative review on the Cannabis Act available to parliamentarians and Canadians?
What is the date? This fall? This fall, yeah.
And you can commit to that?
Absolutely. It's a legislative review.
So, Mr. Johns touched on the fact that so many families are having to mortgage their house, having to go into crazy debt just to put their family into treatment. How much of the SUAP funding is going towards abstinence-based treatment, percentage-wise, or dollars?
So a lot of the SUAP money, you are quite right, is going to harm reduction and safe supply and innovative project. Treatment tends to be the responsibility of provinces and territories. That's why that extra money in the CHT will really matter. So why the $100 million in
Minister, why don't
British Columbia that was in the last budget to be able to go to treatment? Or $1 billion, I think the minister got there.
Thank you, Minister.
Okay, so what criteria are being used to measure the success of BC's decriminalization pilot project?
Okay, there are 6 criteria that were part of the application.
What are they?
The increased in health and social services, continued stakeholder engagement, public education, law enforcement, engagement with Indigenous peoples, and robust evaluation and research as we go forward.
So do you commit to stopping decriminalization should these outcomes not be achieved?
Absolutely. We have always said that if this isn't working, both on the public health indicators and the public safety indicators, we will be watching those. What was really interesting on the safe supply study that was in the CMAJ this year is that decreased visits to emerge, decreased paramedic visits, all of these things that have been part of that London, Ontario project. It's very exciting.
Thank you, Minister.
Minister, there's been countless reports of a huge amount of diversion out of London, and you keep holding London up as if that's somehow the solution. And everything I've heard, I'm looking forward to going to London in a couple weeks, but there's a large amount of diversion. What are you specifically doing to prevent diversion?
The focus is to keep people alive.
But what are you specifically doing to prevent diversion?
I think that we are monitoring that. People are monitoring that people are
So there's nothing specific being done?
Sorry, Leo?
Go ahead and finish your answer. That's the last question. Go ahead, Dr. Bennett.
This is in a comprehensive assessment of all of these safe supply projects. Diversion has always been something that people look at, and it is being tracked.
Thank you, Ms. Goodrich. Next, Dr. Hanley, please, for 5 minutes.
Thank you very much. Thank you, Minister, for appearing, and thanks to all the officials for being here. I'm going to continue on some similar themes, but perhaps in a slightly different frame. In the Yukon, as you know, drug overdoses and deaths continue at alarming levels. Mayo, Yukon is one community that's been hit particularly hard in the last 3 years. Numerous deaths in this small community of a few hundred, and also they were tragically hit by a double homicide in the community, currently under investigation just a week and a half ago. So they have called an emergency order, in order to take some extraordinary measures to reinforce community safety, but also to address addictions and drug trafficking on a more urgent level. And just so you know, one of the asks brought from the community is that supports for private treatment that were provided during the pandemic be extended so that people can have short-term access to addictions treatment in the absence of other options at the moment. But clearly, the spectrum of supports needs to be brought to bear. Preventative measures, including access for children, youth, recreation, mental health support, cultural connection, early intervention, harm reduction, So with social medical supports, including, as you mentioned earlier, opioid agonist treatment, clinical substitution, but also the possibility of safe drug supply for those that can't benefit from clinical OAT treatment, and other measures adapted to where that individual is on their substance use journey, which I think is really the essence of harm reduction as one of those pillars of support. But of course also access to treatment options, including clinical treatment, counseling, and social supports, and aftercare. But in the light of that, I wonder if you could comment on both how the current funding, but also the committed funding from this government, from our federal government, can be utilized to answer to the needs of communities, which we know are across the country. Mayo is in a bad state at the moment, but we know there are many in a similar situation around the country.
Thank you for the question. And of course, the substance use and addiction program across Canada, which Shannon supervises, is doing extraordinarily good work. And the work it's doing is also researched as we go with CIHR and CRISM, that we are able to show what works, and in all of the harm reduction modalities, certainly at blood ties in Whitehorse, to be able to see the drug testing, to be able to see safe injection, safe inhalation, that we know that we are able to reverse overdoses and keep people alive. I think in terms of treatment, that again, so the SUOP money is mainly for proof of concept. When we can prove that something works, then we hope that the provinces and territories will pick that up and put it into their comprehensive approach to their drug policy and programs. And in terms of treatment, I think, whether it's healing lodges, whether it's on the land programs, that I think we're very interested in being able to follow really the science on how effective those are. But I think, as you said, Doctor, the aftercare piece of this is so important, that people have the kinds of supports and services they need through their primary care teams or with the community organizations. We do need that more primary care practitioners, nurse practitioners and family doctors have more confidence dealing with mental health and substance use problems. And that's why I think we're very pleased to see the College of Family Physicians expanding their program for an extra year so that people will come out being much more confident, because it is going to be that front line where we can actually prevent people falling through the cracks.
Thank you. And I wonder, just going back to, and you mentioned it, land-based treatment, and what, maybe you can elaborate a bit on what that means to you as through your experience as Minister of Mental Health and Addictions in particular, but also what avenues there are for Northern Indigenous communities to pursue land-based care and develop programs on land-based care, including aftercare.
Well,
as concisely as possible, Minister. We're trying to get a couple more rounds in. Thanks.
We know that on the land programming has been shown to be very successful throughout COVID, but even before. I think my brother-in-law runs the land-based program in Alberta, where it has been hugely successful because of the quality of its aftercare as well. But that to be out and on the land and is important to all Canadians, but for Indigenous people to actually have that language and culture and be proud of who you are and have that secure personal cultural identity and be good at stuff that's on the land and on the water is really, really important in building that self-esteem and having people being able to see that they could live their best life.
Thank you, Minister. Mr. Thériault pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. Thank you, Mr. Chairman. Still on the rigorous control of budget spending, the Auditor General indicated that the government had paid 5,469,000,000 doses of vaccine in 2020 and 2022. Of those doses, 13.6 million had expired before they could be used, and there was an additional 11 million doses. She said that 32.5 million doses would have expired before the end of 2022. So I'd like to know to what extent we succeeded in using those 32 million doses, and if not, how much of them had to be thrown out in addition to the 24.6 million doses.
It's a time for people to understand that COVID's not over and that we want people to get out and get their shots. And so this is hugely important time, a teachable moment.
Oui, mais c'est pas ma question.
That isn't my question, Minister.
Monsieur Président.
Thank you, Mr. Chairman. 25.6 million doses have expired at the moment. There are many reasons why a dose may reach its expiry date. It may be because the dose has been opened. There's also a refrigeration process involved. And in some cases, there could be damage during transport.
With our global partners to transfer doses between provinces, to work with manufacturers, to extend shelf life in consultation with Health Canada, and donations abroad. We have donated 196 million doses to be used abroad.
24,6.
24.5 or 6 million doses. That's a lot of money. That's a lot of health care that we can't deliver. How will you remedy that? First of all, I think that the priority was to have enough vaccine. Yes, and I agree. I'd like to know how you are going to remedy this situation. Out of time, so a brief answer if you would. We carried out transfers between the provinces and territories. We worked with manufacturers. We expanded requirements for vaccines, and we also looked for international alternatives.
Minimize the number of vaccines that have expired. However, as the Minister mentioned, in order to be prepared and to ensure all Canadians have access to doses, we procured a wide variety of vaccines in significant quantities to make sure that everyone would have access. And I would also just add that ensuring that we promote vaccine take-up and combat misinformation and hesitancy is an important part of ensuring that all doses can be used as effectively as possible.
Thank you. Mr. Johns for 2.5 minutes, please.
We've heard from the Conservatives that in British Columbia they're blaming decriminalization, they're blaming safe supply for the root of the problem of the toxic drug crisis. But the reality is decriminalization didn't start till January 31st. 6 people a day have been dying, and it's been mounting for 6 years. Safe supply, out of the 100,000 people in British Columbia with a substance use disorder, literally hundreds might have access to a truly safer supply of substances. The problem is it's failed drug policy, Minister, that's failed. And, we've heard from the Police Chiefs Association. They can't police their way out of this problem, that it won't matter how much resources they get. They can't solve it. It's easier to get the toxic concoction of drugs almost anywhere in this country than it is to get a prescription at a pharmacy. You can fill it faster. This is a problem. It's the police chiefs that have suggested a safer supply to get people away from the toxic drug crisis, to stop criminalizing people who use substances. This is also reflective of the expert task force on substance use. So my problem with your government is the delay and the lack of rapid response in terms of a safer supply to get out to communities. It's not a diversion of safer supply that's killing people. It's the toxic street drugs that are killing people. So when are you going to scale things up? I keep asking the procurement minister if you've reached out and asked her to procure a safer supply of substances so you can scale things up. When? When will that happen?
So I think that it's really important to understand that they're of the drugs that the community of safe supply practice are using. There's no loss, not insufficient supply of Dilaudid or diacetylmorphine or the drugs that the practice, the safe supply practice is using. The problem is there's not enough practitioners comfortable enough to use it, and so that we have to actually move differently.
Mr. Johns, you took a minute and a half to pose the question. Mr. Johns, please allow the minister to finish. You took a minute and a half to ask the question.
My concern is that in the coroner's report, only 30% of the deaths were people with diagnosed opioid use disorder who would go to a doctor to get theirs. The people are dying are people in the trades, using alone, dying alone, people who aren't going to go to the doctor for safe supply. We've got to find another way to be able to keep people safe.
Just one comment, Minister, really quickly. You spent $30 billion on COVID vaccines. You're spending $32 million on your SUAP program. The stigma's right there.
Thank you.
In the spending to respond to this crisis.
Thank you. We have just a couple more minutes for questions before we actually need to do the votes, and so it isn't enough time for a full round. Minister, if you can stay with us, Conservatives are going to ask you one question, the Liberals are going to ask you one question, and then you're free to go. Over to the Conservatives. One question.
Well, thank you, Chair. Appreciate your flexibility with this. Minister, what we know is that in 2016, 18, and 23, the numbers of overdose deaths have been increasing. This decriminalization experiment, as one of my colleagues has called it, has been ongoing now for at least 2 years in deference to what my NDP colleague said. How many deaths per day are enough to stop your failed experiment?
I would say that I would disagree with you totally on this. The Office of Public Prosecution asked people to stop charging people years ago. This has been going on for a long time. It isn't that we have to take the stigma down, get people to treatment, and it's not the failed experiment. It's that the drug supply is totally toxic and poisoned with fentanyl, now benzodiazepam, the naloxone isn't working as well, now with xylazine, that this is a toxic supply and we have to get people to stay alive long enough to be able to get to treatment or live a better life. This is nothing to do with decriminalization. Cops have been not charging people for years now.
Thank you, Minister. Ms. Sidhu, last question.
Thank you, Mr. Chair. Thank you, Minister and official. Your important update. Minister, I want to speak when we did a roundtable in Peel, and they raised that the wait time in Peel for counseling and therapy for those under 18 years reach up to 566 days, and over 2 years, more intensive mental health service. And the Mental Health Commission of Canada's report on mental health impacts the COVID-19 on youth, especially on youth, which can lead to social isolation, family stress, increased risk of exposure to abuses, and systemic racism. And many face disproportionate challenges access mental health supports. This is all came into the report, and you heard on the first hand in Brampton too. So there's a need of integrated youth services, and how you can think or you can comment on this. You did an important announcement to $1 million to Indus Community Services, but how you think this is ensuring access to youth, which is more culturally appropriate, are sensitive, so the youth can get all the services.
Thank you for that, and thank you for hosting the roundtable. And I think that we learned a lot there about the need for culturally safe care. Last week in Surrey, we actually with our colleagues, Suk Dhaliwal, the idea of even detox and withdrawal home visits based on the South Asian community and their cultural reality was really, really important. And I think that for us to have the 1 million for Indus for that community focused on youth is going to be really important, because the stigma in your community is very high, and that we actually have to find culturally safe ways of decreasing the barriers so people can ask for help, and particularly young people. What I'm hearing is from our colleagues is that it will be the youth that will persuade their parents and their grandparents that it's okay to talk about mental health, and that we need to focus on the mental health and that's culturally safe, and that's why integrated youth services is so exciting coast to coast to coast, because again, it is that step care model with peer support, people who with lived and living experience, who are the first people that somebody meets in the door, and that they're able to get them attached to primary care, social work, psychology, that this is a very, very exciting approach. And I think that this, with the $100 million that was part of those communities most affected by COVID, that this is very exciting to be able to see the results of that, and for us to move forward in those in most need.
Thank you very much, Minister, and thanks to all of your officials for being here with us today and for being so patient with us. We're going to move now directly to votes, but please know that we absolutely appreciate all of the information that's been provided here today and the manner in which it's been presented. So that, with the time we have remaining, we need to vote on the main estimates. So the first of all, we have 11 votes in the main estimates 2023-2024. Unless there is an objection, I'm looking for unanimous consent to group the votes together for a decision as opposed to doing 11 votes. We're okay. I see thumbs up all around the room. The question then is, shall all votes referred to the committee in the main estimates 2023-24, less the amounts voted in the interim estimates, carry?
On division.
Carried on division. Shall I report the votes back to the House? I think that is all the business. Is there any further business to come before the meeting?
I move to adjourn the meeting.
Do we agree to adjourn? The meeting is adjourned. Thank you.
you.